The circulatory system carries oxygen and nutrients to our cells. It brings our body's defenses to attack disease. We need it to work properly. Heart and circulatory diseases tonight, On Call with the Prairie Doc. Good evening and welcome to On Call with the Prairie Doc. What goes around comes around, and when you're talking about our circulatory system, keeping it going around is important. First, let's take a look at this week's Prairie Doc quiz question. The risk of heart and vascular diseases are better reduced by 1, lifestyle changes such as regular exercise, or 2, statins and other cardiovascular drugs. Viewers who call in the correct answer will be entered into a drawing to win a signed copy of our book, The Picture of Health. Each of my essays, originally written for this show, comes with a wonderful accompanying photograph by Dr. Judith Peterson. We will announce the answer and the winner at the end of the show. Remember, you only have 10 minutes to get in your answer, but we will answer your medical questions about heart disease and circulatory diseases throughout the whole show as they're called in or sent to us via Facebook or email. Call in your questions to 1-888-376-6225 or send us an email to the address on the screen. Joining us in the studio tonight is Dr. Michael Bacharach of North Central Heart, a division of Avera Heart Hospital. Thank you for joining us, Mike.
Thanks, Rick. It's nice to be here.
And as someone asked earlier, they really like your music, but that's the wrong Bacharach.
Yeah, I wish it was my music. That's right. Yeah. That's exactly right.
So you're originally an internist.
Yes.
Explain that.
Well, my basic training was in internal medicine, and then I did a subspecialty in cardiovascular disease, so cardiology per se. But I did a special emphasis in vascular medicine, and then did an interventional fellowship, so we learned how to do balloons and catheters and those sorts of things. And so that's, and it was at a time when not many people were in that sort of field, and that field has changed and evolved, but that's how I got started.
Well, I was at Emory in Atlanta when this whole balloon angioplasty thing with Grunzig.
Yeah, Andreas Grunzig. Mm-hmm.
Yeah, had you ever met him?
No, I never did.
Yeah, well, he died really young. I mean, I don't think it says anything about the field, but he was in an airplane
accident, yeah. So.
But that whole idea, explain how it evolved.
Well, actually, it goes back even a little further. It goes back to a man named Charles Dotter, who was at the Oregon Health Sciences, who had first postulated that you could open these arteries by dilating them with a dilating type tube of that sort of thing. And then that was considered heretical. He was not well received. Ultimately, then the balloon concept came out, which developed in Europe, and Andreas Grunzig basically came to the United States from Switzerland to help develop that. And of course, that then led the way for balloon angioplasty, both in the arteries in the legs, for example, peripheral, and then with coronaries. And of course, it then evolved into the development of stents that then act like a scaffold to hold that artery open. And of course, the technology's just taken off.
Right. So, I mean, they used to just dilate it and then hope that it would stay open, and it did stay open in a good percentage.
It worked fairly well. Remember, it's kind of a controlled injury, so you were pushing the plaque out of the way, and then the artery would remodel and kind of heal itself. There was a problem with elastic recoil, so that sometimes the initial result didn't last very long, so there was high rates of re-narrowing. Stents then helped that, and again allowed for a scaffold to kind of hold that artery open. We now have drug-coated stents that not only help hold it open, but release a pharmacologic agent that then prevents that from re-narrowing. And so the re-narrowing rates have markedly reduced, and of course that's had a tremendous impact. We do far less surgery now than what we used to do.
Yep, you told me that you had, what, 1,200 done in a year, and then now we're down to 350 or something?
Yeah, it's about a third of what we once did 20 years ago at the same institution, that's right.
But there is some argument that that stents haven't reduced the death rate or the MI rate, it just reduces pain. What's your counter to that?
Well, I, to some extent, I think that's a true statement. What we have, what we when we treat patients with bypass or stents, balloon angioplasty, a variety of things, what we're doing is we're treating their discomfort. We're allowing them to exercise better. We're trying to improve blood flow to the heart. That's true, but predominantly it's angina or chest pain that you get with exertion that we're treating. And it has not been, except for a few exceptions, been shown to really prolong life. The real impact has been on modification of lifestyle and the statin medications, particularly those things, the statin medicines that now reduce cholesterol and lipids. They've really had a tremendous impact on the reduction of recurrent myocardial events and have allowed people to live longer. So it's a combination of things, but I would tell you that the new medicines that we now have had a dramatic impact.
The issue of other procedures doing besides just dilation of arteries to the heart, you are now dilating arteries that feed the kidneys, that feed the legs, that feed the brain. Talk about some of that.
Well, so with the development of technology and the miniaturization of these devices, they now have, you're right, we can fix arteries that are blocked almost anywhere. I personally don't do intracranial work, but there are people now who can stent and fix aneurysms in the brain or blockages in the brain with little tiny catheters. Carotid arteries, which was previously the purview exclusively of the open surgical procedure, now can be done with stents using embolic protection, which is a little filter device that prevents any material going up.
You put a little umbrella on the other side.
That's exactly right.
Dilate it up, any little pieces
That's right.
slip into the umbrella.
Yep, that's exactly right, and then you take the umbrella out. I think the other tremendous inroads and new devices really have been in the area of structural heart. So we now have the ability to, if there's a hole between the two chambers, the atrial chambers, for example, you can go in and put a small clamshell-like device, close the hole, and you don't have to open the chest anymore. Aortic stenosis is another thing. We've now been able to implant new aortic valves in people just going through a small tube through the groin and no longer have to put them on heart bypass. So it has dramatically changed, and it's not for everyone, but it's these kinds of things that will continue to evolve and have dramatically changed the field of cardiovascular medicine and intervention.
So you're also a teacher.
Well, I try.
Okay. You have residents from the Mayo that follow you.
We
Explain that story.
Well, so, as with many specialties, as new technology has come along, people need to learn how to do that. And that was not part of the standard training that was done for vascular surgeons at the Mayo Clinic. And they often didn't get much experience with trying to do some of these endovascular procedures, which are basically what you're doing is fixing the artery from the inside out as opposed from the outside in. And so I was approached now about 10 years ago by the director there, who's actually, by the way, a South Dakotan, Tom Bauer, and a very accomplished aortic surgeon. And so Tom asked if we would take some of the fellows on and try and work out a program. So we have. So now for the last 10 years, the fellows rotate through with us, spend 3 months with us, learning endovascular things and aspects of vascular medicine. It's been very rewarding. I think they like it, and it's been very rewarding for me.
Right.
It's pushed me, though, I have to
Yeah,
tell
I
you.
suppose. These darn students make you
They
better.
ask questions that
Yeah,
sometimes you don't have the answer to, so that's right. That's right.
Questions that you keep
That's
answering.
right.
So is there any other place that those residents go?
No, they don't. It's fairly limited, and there are specific rules within the training program. So I did get a faculty position there, and so there's the accreditation process is such so that, yeah, as far as I know, we're the only site, outside site that they use, and certainly the only site here in South Dakota.
So not only are you a North Central Heart, a Verita heart doctor, but you're also a Mayo Clinic professor.
Well, I am, yeah.
Yeah.
Hard to believe, isn't it?
Yeah. Just a South Dakota guy. So I do know that they've been pushing now to have coronary bypass graft and stent of stents on diabetic patients who have coronary artery disease. Explain that.
Well, the everyone would like to have things done less invasively. I mean, all of us. I mean, I'm the same way. But in fact, it has been shown that there are certain subpopulations in which surgical bypass may be a better long-term. Now, there's an upfront cost. I don't mean financial cost, but a cost of discomfort and the fact that you have to have your chest opened and so on. But that often the durability of an internal mammary artery graft, for example, is significantly longer. Diabetic vessels often are much smaller, often have calcification in them. They're harder to stent. You don't get as good a result. And so there are subgroups that clearly still do better with open operation. So it's still a very good procedure, and one that sometimes I think honestly gets a little bit overlooked. And you have to be careful not to try and sell the less invasive way just because it's easier. Sometimes the easiest isn't the best.
Not the best.
Right.
Yeah. Weakness on one side of the body or blindness in an eye can be warning signs that you're susceptible to a stroke. It's important to seek medical attention if you have these symptoms.
Well, carotid artery disease is what we mostly see is atherosclerotic disease, and as we age, it's dangerous because it can cause us to have strokes. For it sooner, you also can see it after stroke. People will look. When you go to your doctor, they will listen to your neck with a stethoscope. If they hear a bruit or a tightening of the artery will cause noise, and that will lead them to do a sound wave test of the artery. The sound wave artery will look at both the internal and the external artery. There's two branches in the neck, and the one that goes to the brain, if that one has disease via an ultrasound, then you may be referred for another test to see if it's really significant. The risk factors for vascular diseases are the same for heart diseases. Diabetes, if you're diabetic, treat it. With carotids, probably your highest risk factor is hypertension, so if you have high blood pressure, you need to treat it. High cholesterol is one. If we do find disease in the carotid arteries, we put them on antiplatelet medications, treat their hypertension, and often a statin for high cholesterol. If you have a carotid bruit when they listen in your neck, it's very reasonable to have an ultrasound to make sure that you don't have severe disease. If you have severe disease, it's reasonable to treat. If you have had a weakness on one side of your body or blindness in an eye, those are symptomatic. People with symptomatic carotids are the most highest risk of having a stroke. So this patient had an ultrasound that showed severe disease in their internal carotid artery. That's the branch that goes to the brain. Is this one. Here's the common, and the one with the branches feeds the face we don't worry about. But the one to the brain has a very tight stenosis in it, and people with tight blockages in their internal carotid arteries are at higher risk to have a stroke. When we do an operation, we will often put a little plastic tube in so blood goes around the blockage when we clamp the artery and have it open. So we still protect the brain that way. So either way, you should have some way to protect the brain while you're working on the carotid artery. If we take the plaque and push it up against the wall and trap it in the stent. When we do this, we also have a little protection device in, which is necessary because any of the fine material that gets out could go to the brain, and that's one of the risk factors that we have to make sure that there's protection so when we open the artery up, nothing gets away to the brain. The bottom line is if you have symptoms from the carotid, that's weakness on the opposite side of the body. This person with a right carotid would have had a left arm or left leg weakness or blindness on the same side eye. If you have that, your chance of a stroke is about 30% that year. So that's very important. If you're having warning signs of a stroke, similar to having chest pain before having a heart attack, those people should be addressed and looked at because even though everything we do in medicine is expensive, it's more expensive to have a stroke than not have a stroke.
Did you see how that clock ticked off 4 minutes? Every 4 minutes there's something happening here. This is your show, and your questions are key to our show discussion. So please call in your questions about heart, circulatory diseases to 1-888-376-6225 or send us an email to ask@prairiedoc.org. So interesting, your partner in crime there, Tommy Reynolds, was interviewed talking about carotid disease. And anything you'd like to add?
No, I mean, Tommy did a very nice job in explaining the carotid artery narrowing. and the various options, including an open operation versus a stent. Both are being utilized. Certainly in higher risk patients, the stents may be an option. You don't have to put someone to sleep, especially if they have severe lung disease or severe heart disease. So it's been, again, that's been new technology now that's it's been around a while, but it's worked out really very well for us. Again, the emphasis now with stroke has been important. We have, nowadays we can give tissue plasminogen, blood clot dissolving medicine,
Right.
if a person presents
Early enough.
and that now has been extended a little bit to, initially it was 3 hours, then now out to 6 hours. I think that one of the things that is frustrating from a clinician standpoint is that people often stay at home. They have symptoms, they get weakness in an arm or leg, they drop their coffee cup, and they think, oh, it's nothing, or it'll go away, or I slept wrong on my father had a stroke. And he called me and said, gee, I think I just slipped, I took a nap and I slept on my arm wrong, and now it doesn't want to work right. I said, Dad, you're having a stroke. So, so I had a friend take him to the hospital right away. But I mean, it's those kinds of things that people often don't want to acknowledge that they have an issue or a problem, and it's you really do yourself a disservice if you stay at home. If you have a question, go in and be evaluated.
Exactly right. We had a gentleman well known in this community who had a prediction that it was going to happen the day before he had a big stroke and lost a great deal of permanent function. And he could have had that opportunity, that window of opportunity was there, the window closed,
Right.
and there it was. It's just that same story you talked about. We've got some questions, and we appreciate your questions. What percentage of heart attack patients go to a cardiac rehab in South Dakota? Is it effective in reducing future heart events? So how important is cardiac rehab?
Well, cardiac rehab really is essential, and it's a very important component of the entire, of being a holistic way of treating those patients. Ideally, we would send everyone to rehab. Now, unfortunately, we are a geographically isolated state, and there are some patients that live in rural areas where they don't have it available to them.
That's right.
And that's unfortunate. But cardiac rehab is really probably, from a cost-effective standpoint and a benefit-effective standpoint, it's one of the most important things that you can do. Now, most patients will go typically to rehab for 12 weeks following a operation or following a myocardial event. And it's our hope that many of them will retain what they learn at rehab so that they can do some of that on their own.
There's some unbelievable number, like 40% reduction, compared to, it just pales every other method to lower recurrent events. So, I mean, by far the best idea is to get into an exercise program.
Absolutely.
And a rehab program is so, so important. Caller would like to know if emotional state affects cardiovascular health. For example, grief. Do you think how much of what happens to the heart and the heart vessels and all the vessels is related to our emotional status?
Well, the concept of stress has been around for a long time, and how it contributes both to behavior, to sleep deprivation, to many things that in fact can affect cardiovascular health. Now, there are a few circumstances when severe grief, for example, can cause significant decrease in heart pumping function. And we've seen this ballooning thing, Takotsubo. Right. But it's a relatively uncommon phenomenon. But it can occur, and most of those patients with medication will normalize. We don't really understand that. So I think there are components clearly of severe grief or stress that are a contributing factor, but I think stress in general, it's very hard to say exactly what role and how important it is.
I do know that if you look at a variety of studies in general internal medicine world, that people who are involved with severe depression and with smoking and alcohol, all three of those truly affect longevity, way more than probably any other factor. And so grief is a significant risk factor, and I think the most important thing anybody can do with grief is to seek help. Maybe it's your friend or your minister or your priest or your counselor or your doctor, but seek some help. What's the latest treatment for atrial fibrillation or fibrillation, depending upon how you pronounce it?
Well, the easiest thing to do is to send the patient to one of my partners who's an electrical specialist. But you know, atrial fibrillation is very common. It's become much more common, particularly as an aging population. So we're seeing a great deal more of it. The first thing you need to understand is that atrial fibrillation in and of itself doesn't damage the heart. It does pose some risks, and in some patients it can reduce the effectiveness of their pumping function. There's a risk of stroke associated with atrial fibrillation because clots can develop in the upper chamber portion of the heart. There are a host of medications, and so the first step is medication, number one, to control the heart rate so it doesn't go too fast. And then there are medications to try and control or put the heart back into sinus rhythm. The new technologies nowadays, they're really divided, I think, in two. One is to try and get the heart back into sinus rhythm, and there's this pulmonary vein isolation technique, which is an ablation technique where they go in with a catheter and try and basically ablate that little spot. So it's, if we look here, it's usually on the pulmonary outflow tract, and it's hard to see here, but it's right along in here, and in here, and here, and here. And they actually can ablate those specific areas, and that's where the focus or that electrical stimulation occurs that causes the atrial fibrillation. Now, that's an effective technique. One of the other things is that there's, what you don't see here, there's a little atrial appendage that sits out here, and this is where the clot tends to form. And so now there's some new devices that they can actually go in and go across here, and they put a little device in here to kind of sort of fill that spot, and basically what that then does is it reduces the risk of stroke. So in a person who has atrial fibrillation that you can't get them back into sinus rhythm, again, treatment would be blood thinner, and now we have a host of different blood thinners that we can use nowadays, but there's also this atrial appendage device that's now been, it's called the Watchman. So there's lots of new therapies for atrial fibrillation. First step is to determine, can we get you back into sinus rhythm, can we control the heart rate, and then deal with the other consequences of the atrial fibrillation.
I would only add, new finding is that a common cause for atrial fib is sleep apnea, and we have we've not recognized that as a real source in the past.
Right, that's a good point. So we need to advise the
primary care doctor.
Well, I was going to say that most of the wives know that their husbands snore, and so one of the risk factors, if your spouse snores or has episodes where they kind of quit breathing in the middle of the night and you have to poke them, those are patients that need to come in and be evaluated. You're right that sleep apnea has been under recognized and undertreated.
Yeah. So when you said sinus rhythm, as opposed to atrial fibrillation, what does sinus mean?
Yeah, sinus just means that the upper chambers of the heart are beating in a coordinated fashion with the lower chamber. And the upper chamber tends to contract just slightly before the bottom chamber, so it helps fill that bottom chamber, and it does it in concert. So it's meaning it's sinus, so each time it goes, and they're coordinated. With atrial fibrillation, the upper part kind of fibrillates and doesn't fill very effectively.
Okay. What are the main causes for heart disease or vascular disease, and how do you treat these conditions?
Well, as was evidenced in the video that Dr. Reynolds talked about carotid disease, and again, what I tell patients is that if you have, mineral deposits in the pipes in your house, it doesn't happen just in the house, in the bathroom or just the kitchen, right? It happens throughout the house.
Throughout the house.
So the potential for blockage and the atherosclerosis, or this hardening of the arteries process, is one that can affect all of the arteries in the body. And why it occurs in some people more than others, we don't fully understand. The one risk factor that I would have admonished Dr. Reynolds about is that he didn't mention is smoking, tobacco use. Tobacco use is worth 3 of the others. It is probably the most significant contribution to the development of hardening of the arteries. And if you think about it, the lungs very effectively absorb all of those various organic compounds and the materials in the smoke. takes it into the bloodstream, and it coats the inside of your arteries. And so that is really one of the major issues. So the cause of peripheral vascular disease and heart disease is, again, multifactorial, number of things. Certainly genetics, can't do much about our family history.
No.
But we can do things about diabetes and control it. We can do things about hypertension. And tobacco use really is the bigger issue. And then, of course, cholesterol medications.
I would add, and I think this is the premium, is that the new smoking is the couch. And we need to try to encourage people to get off that couch. And if you can walk 30 minutes every single day, then you have a huge
Well, you know, it's
hands up.
And I've told this story many times as well. You know, when I was first a fellow and we didn't have all of these endovascular techniques, someone would come in and couldn't walk, but they didn't have sores on their feet. They just couldn't walk very far.
Right.
And we'd say, well, you know, get a rocking chair and sit on the porch and
Don't walk.
Right, because the only options that we had were an open operation, and typically we didn't want to subject them to that. Nowadays, with endovascular techniques, we can do things that we couldn't do, and much less invasively. And the point was that there were some very elegant studies that have looked at the effect on aerobic exercise. It prolongs survival. These people do better. If you let someone, if you let them languish and they can't walk, they can't aerobically exercise, potentially you're condemning them to a premature cardiovascular death. So exercise is really important, and of course, exercise is also important to manage weight, which is another one of our problems here, especially in the food belt.
Right. It seems that most of the 80-year-old men I know have had heart trouble. How common is it for someone to survive a heart attack?
Well, nowadays
It's different than it was. Why is that?
Well, nowadays, the vast majority of patients do survive heart attacks. It's because of early recognition. It's because of new medications that we have. It's
AEDs.
AEDs that we have. So
Which
we
are
have
what?
They are a defibrillator type device, so that if you develop a heart attack and the heart muscle isn't getting enough blood, often it causes an electrical disturbance. So the heart will race and then sometimes fibrillate, where it just stops. And as a result, that causes sudden death. So now being able to shock someone, the first responders now, you know, again, having defibrillators, our paramedics and our emergency personnel are superbly trained, and so we have lots of tools nowadays. So if people come in early, they generally do reasonably well.
I've got at least 3 or 4 friends, patients who are alive because of early shock, and I have lost friends who didn't have that shock and we wish they had.
Mm-hmm.
Sudden cardiac arrest is a common healthcare problem that can occur in an estimated 500,000 people a year. Automatic external defibrillators, or AEDs, which are increasingly available in public places, can restore a normal heart rhythm. Here's a demonstration.
We're here to talk about AEDs today and the Heart Association and CPR. Why are we talking about that? Well, first of all, you need to know that heart disease is the #1 killer of men and women in the United States. It's a first world problem. What happens if somebody goes unresponsive? The first thing you want to do is make sure the scene is safe. Is where this person has fallen a good place for you to help them? Because if there's a fire, or it's in the middle of traffic, or you're on a sidewalk and it's an ice storm and branches are falling, it's not going to be a safe place. So you need to make sure the scene is safe. The second thing you want to do is come up to the person and touch them. Sir, are you okay? Are you all right? Take about 5 to 10 seconds to do that. And yes, it's okay to touch them because they might need that stimulus if they've just passed out or fainted. After 5 to 10 seconds, holler for help if no one's around. Help, I need help. And then check to see if the person is breathing. Is there movement on that chest? Again, take about 5 to 10 seconds to look for that. If you don't see movement, then say, someone call 911 and get an AED. Then you need to start compressions. Now, how do you do compressions? Well, women have less upper body strength than men do. It's just a fact. So what we need to do as women is make sure that our upper body is over the chest of the person who is going to need compressions. Take the heel of one hand, put that in the center of the chest, which is the lower part of the breastbone, Interlock your fingers and make sure the heel of the hand stays in contact. Your arms need to be straight. Don't bend your elbows. You're going to push hard and fast in the center of the chest to a depth of about 2 to 2.4 inches. So we're going to count out loud and go at a rate of 100 to 120 per minute. And so we're going to just count out loud so we can keep track of our compressions. 2, 3, 4, 5, 6, 7, 8. Now maybe by this time somebody has come and brought an AED. If they bring an AED to you, you can keep doing compressions, and you can even direct them what they need to do next. We need to open the lid and then power on the AED, push the on-off button, and after that, follow the prompts. Whatever the AED says to do, that's what you need to do. So you want to verify, did that person call 911? If there's clothing, we need to make sure the patient has an open chest, a free chest that we can work on. Now notice, there's no envelope
Pull
here.
red handle to open bag.
Normally there's an envelope that we would pull to open, but since that's been used,
Look at pictures on pad.
we need to find the ones in the lid.
Peel one pad off blue plastic. Apply pad to bare skin, exactly as shown in the picture. Press pad firmly. Peel other pad off blue plastic. Apply pad to bare skin, exactly as shown in the picture.
Everybody clear.
Shock delivered. Provide chest compressions.
Now I'm going to stop, but if this were somebody who really needed my help, I would keep going because you're going to hear the AED prompt you to continue care, and it will do that for 2 minutes.
Continue care.
We need to do compressions for 2 minutes, and then it will say again, do not touch patient, evaluating heart rhythm. And it will tell you again, do not touch patient, delivering shock if a shock is advised. Sometimes the AED will say no shock advised. At that point, go back to doing compressions. If you're thinking, well, what if they have a heart rate, or what if there's a pulse? You know what? You're not going to harm them if you're doing compressions and they're not responding. So if they start moving, their eyes open, they're trying to swing at you, you can stop compressions at that point. Quick access to care, which is what we're doing, is giving them hands-only CPR, somebody's calling 911, somebody's applying defibrillator, is going to increase their chances of survival.
Wow, that was great. My director said, I love this woman. She just brings it. So great job. Thank you for that. I thought that it's important that you don't need to do mouth-to-mouth anymore. I mean, that's the thing. What do you know?
Well, and again, I mean, I think she gave a very nice demonstration. You know, one of the things that people may be a little bit intimidated by that AED, but they need to understand that it's really very simple to use. If they can operate a cell phone, they can operate that device.
Right.
It's automatic. They put the pads on as was demonstrated, and then basically the device does the rest of the work, and it really does make a huge difference.
Wow. So think about it. Don't hesitate if it happens. Well, let's dive into questions. We
Okay.
got wonderful questions.
All right.
Thank you. How are teeth related to heart disease?
Well.
Anaerobic infections in the
Yeah,
mouth. And
you know,
infections.
I mean, again, there's some theories about how they may affect,
Yeah.
and you know, the idea that there may be an infectious etiology or infectious cause of vascular disease or atherosclerotic disease. I don't know that that's all been substantiated. There's an avian, atherosclerotic mechanism for infection, but. I think the bigger issue is, certainly if you have a device in place, if you've had an aortic valve replaced or you have a prosthetic graft in place, then when you go to the dentist, the problem is that you can get bacteria in the bloodstream and it can get infected. So there are some precautions that we have, and some patients who have had intervention, who have had these artificial devices, do need to take antibiotics, and we're pretty good about telling them that. So most of the patients who have that would know.
I know for a fact, though, people who have bad teeth have problems with anaerobic lung infections. Whenever they brush their teeth, in fact, whenever any of us brush our teeth, depending upon how bad our
Right.
teeth are, we're seeding
Right.
the blood.
Right.
So there's a significance It's not well defined. It's amazing
Right.
how well we do with the crap in our teeth.
Right.
Dry eye syndrome has increased risk for stroke. How can we prevent it? How common, and how soon will the stroke come? So dry eye syndrome, have you heard that?
Unfortunately, I can't comment on it because I'm not aware of that.
Okay, so I'm
learning something new here. So I
I'm the
didn't know that.
internist. It's called Sicca syndrome, and I wasn't aware that it increased stroke either. I did not know that. So I apologize. I will look into it and have some information for you on the next show. So, don't know. I wasn't aware of it.
I don't know.
I had high blood pressure and weakness on one side of a body a while ago. CAT scans, MRI, all came back okay. 1 week ago, I went into family doc feeling bad and was fine. Blood pressure was high again today. Should I go into the doctor again? That's interesting. Stroke-like symptoms, workup was negative, blood pressure's high.
Right. So, I would go in to see the doctor primarily because you want to check that blood pressure. High blood pressure clearly increases the risk of stroke. There's a 7-fold increase in stroke risk in patients who are not adequately treated for their blood pressure. So I would. Could
How about
there
an
be,
ultrasound of the carotid? Would
well,
you do that?
sure. I potentially would. I'd examine the patient obviously first and see if they have a carotid bruit and so on. Hypertension alone, remember, many strokes can be related to lacunar infarcts or what we call little tiny blood vessel changes in the brain itself that are related to hypertension. And so it would be important to be evaluated.
Yeah, I like the idea of getting that blood pressure controlled. Wow, is that an important thing? 71-year-old woman who has had aortic sclerosis and an aortic valve replacement. Family history of cardiovascular disease. How often should I get a checkup?
Well, again, I don't know the exact timing of that. I presume that she, with an aortic valve replaced, that was done probably surgically, if it was because it's really the new transaortic valves that we're placing now are relatively new. Some of it depends on symptoms. Most patients are put into a surveillance program. Typically, I would see those patients back on a yearly basis with one of those ultrasounds called an echocardiogram to look at the valve and make sure that it's functioning. It depends a little bit, is it a mechanical valve or is it a bioprosthetic valve, meaning a pig valve or a bovine cardiac,
She's pretty young. I mean, 71, and she's had this surgery before.
So I would have guessed that it's probably a mechanical valve, and so if she's on blood thinner, but the bioprosthetic valves have the advantage that you don't need to be on blood thinner, but they do tend to wear out sooner. So there's a little bit more information that we would need to really advise her specifically.
I certainly would say a regular walking program every single day, 30 minutes. Can the doctor talk about the new cholesterol-lowering drugs versus statins that might not be as beneficial to the patient?
So there are some new medications. Some of them actually are immunologically used to reduce cholesterol. Some of them are injectable. Honestly, I think at this point there are some initial data suggesting that they may be a benefit. Are they being used on a wholesale basis at this point? No, they're not. The statins still have been very effective, and often you just have to try a different statin, even if you have a response to one. And again, I'm not a specific expert on all the areas of cholesterol, of the new medications now, but there are, again, continued developments now. So
I wouldn't use them until they show reduced death rate from them, and I haven't gotten that yet. And so I'm more of a critical person as far as the statins. I don't think any of them hold a handle to the lifestyle changes that we should be
that's
pushing.
probably true.
EKG results, a normal ejection fraction is around 50 to 70%. Mine is, that's probably echo results really. Mine is 35 to 45%. My mitral valve shows mild leaking. What kind of trouble am I looking at, and what can I do? We don't know how old she is. She's at 35 to 45. What do you think?
Well, I mean, that 35 to 45, again, we don't eject the entire 100% of the blood every time it squeezes, okay? So estimate that and with echocardiogram, and there's some other techniques too, but we would, anything for above 50 would be considered normal. So 50 to 70 is pretty normal. So 35 to 40% is at least a moderate reduction in the pumping fraction. A lot depends on how symptomatic you are. There are people who have 35 or 40% ejection fraction, and they have good stamina. They have good functional level. They can do everything. And there's others that are significantly impaired. Depends on how big the ventricle is. I mean, there's a number of other factors. So with only mild mitral regurgitation, you wouldn't necessarily do, you certainly wouldn't do a valve replacement for that. There are some medications that can be used to try and, again, manage blood pressure, to slow the heart perhaps, to allow it to pump a little bit better. Again, it goes back to what's the underlying cause of that reduction in ventricular function. Did they have a previous heart attack? Did they have a previous myocarditis with a viral infection? Right. Did they have
I don't think it's the mitral valve that's really done it, do you?
No, I don't.
No, so 35, 45%, I would, make sure you're on lisinopril or one of the prils. I like one of the new beta blockers that are, carvedilol.
Or carvedilol.
And then enough diuretic, and you can manage that person and live a long time, don't you agree?
Yes, I agree.
I had a heart attack in May. I still don't seem to have much energy. Should I be concerned?
Fatigue and decreased energy is a very complex problem, and it's one that you see and I see, and often there's not one specific answer. What's the threshold for aerobic exercise that you're currently doing? Did you participate in cardiovascular rehab?
There we go.
How well is your heart pumping now after? Not all heart attacks are the same. Some involve a larger blood vessel or a main blood vessel around the front wall of the heart that can have significant impact. Is your fatigue and decreased energy all related to cardiac function, or is it other things?
Emotional.
Right.
Yeah.
So those are all. It's a
mixed bag.
Right. So you need to see the cardiologist though, or whoever's looking after you, to make certain that the heart pumping function is okay and that you're doing the right type of medications, that you're doing the right lifestyle changes, and that you're at least engaging in cardiac rehab or some kind of physical exercise activity.
Yeah. We've got 2,472 more questions to go, so
Okay,
you better
all
be
right,
pretty quick.
okay, all right.
Wonder if numbness in the upper lip 3 times in 6 weeks is a sign of cardiovascular disease.
Periorbital numbness can be a variety of different things. It can be related to minor nerve things in the face. It can be related to hyperventilation. It can be related to migraine headaches. I mean, there's a variety of different things.
And maybe a little TIA, too.
It could.
TIA.
So, yeah.
But I have not heard that as a common sign.
So, right. So I would.
You're skeptical.
Right, I am.
I feel you're skeptical.
Yeah, okay. I am skeptical.
But it could be. So seek some help and get it evaluated. I have a fibrillating heart, and I take water pills every day. I'm 83 years of age. How long can I keep on going like this?
That's a good question, and I wish I had a crystal ball and could tell you that. Atrial fibrillation, people can live normally and they can live a normal life, and the determination of length of life is a big part of its genetics and lifestyle. How long did your parents live? How well do you look after yourself? That sort of thing. Atrial fibrillation alone, as long as the heart rate's controlled, it should not be a life-ending event or limit your life.
I think she'll live 10 years or more, but then what do I know? My wife had a stroke a couple years ago. She is slowly trying to get back to her feet. What kind of time frame can I expect for her to recover? Is there a time where it doesn't get any better and we reach a peak?
That's an interesting question, and I think there's a fair amount of research now in sort of neurobiology that has recognized that patients can continue to improve. Initially it was thought that if you weren't better within the relatively few months, you weren't going to get any better, and we found that that's just not true. What happens is that people get discouraged and they quit rehab, or they don't work as hard at focusing and trying to concentrate. The brain can learn new things. And again, I'm not a neurologist and I'm not an expert in this particular area, but again, from personal experience, my father who had a stroke, after it was a number of years that he improved, and actually he drove again, and he had a pretty substantial stroke. So you can retrain the brain, and so my idea is don't give up, continue with your efforts, and I think that to some extent they'll be rewarded.
Keep it up. Yeah, beautiful. Is there any treatment for heart failure?
Yeah, there are lots of treatments for heart failure, and again, it depends on what kind of heart failure, and not to make it
Systolic versus diastolic.
diastolic, right? So systolic means that the heart doesn't pump well, and so it doesn't eject the blood. Diastolic means it doesn't relax very well, even though it pumps, and so as a result, the filling isn't, and it's not very efficient. So it depends. But we have medications. You mentioned diuretics, water pills that are used to help reduce the amount of fluid that builds up. We have medications to slow the heart so that it pumps more efficiently. We have medicines like digoxin, which aren't used very much anymore, but still, may slow the heart and may in fact allow it to contract a little better. Again, it depends a little bit on what the cause is. If it's permanent damage to the heart, is it temporary? Is it, were there electrical issues? All of those things play a role in how we manage heart failure nowadays. The biggest issue with heart failure, though, and a typical congestive heart failure with systolic dysfunction, is you need to watch your weight on a daily basis, and if it starts going up, that means you're accumulating fluid, and you may need to change medicines. You need to watch your salt intake, because water follows salt, and so it's that smoked ham at Christmas time that suddenly
might get you into trouble.
Might get you into trouble. That's right.
I had a patient who had a 20% ejection fraction. Everybody talked about, we had 35 to 45 before. 20% lived, he's still alive. I mean, he's had it 20 years, keeps getting a little bit better, does his walking like he can. Caller has multiple heart scans which do not display any cholesterol in his veins, and he's wondering if there's anything else he can do to establish how healthy his cardiovascular system is, and if the heart scans are reliable. It sounds like he's got a pretty good heart, doesn't it, to me?
It does. Again, it depends a little bit on what the underlying reason for the heart scan was.
Right, he must be having chest pain.
He must have had something, so usually. But, the ability to aerobically exercise, and we keep getting back to this, but that's probably the best predictor. We know that if you can walk up 2 flights of steps, if you can aerobically exercise, if you can walk for 30 minutes, all of those are the kinds of things that are far more important in predicting how well your heart works, and actually are indirect predictor of survival. So exercise and your functional ability. So if you're on the couch, get off of it. If you can get into a regular exercise program, that would be important. If you have a weight issue, try and reduce your weight. All of those things would be helpful.
Great. We've got a bunch of questions. We're going to answer them online. You can go to the internet site, prairiedoc.org, and get the answer to your questions that we couldn't get to. And now for the winner of tonight's Prairie Doc quiz question. The risk of heart and vascular disease are better reduced by 1, lifestyle changes such as regular exercise, 2, statins and other cardiovascular drugs. And the correct answer is number 1, lifestyle. Now, do you agree?
I do agree.
Who could have guessed? It was Susie McMartin from Brandon, South Dakota, who answered the question correctly. Thank you, Susie, for participating, and a book will be in the mail to you soon. We'll be right back after this.
Good day, citizens. It is with regret that I inform you that the end is near for me. I'm old, I'm tired, I'm weak. But don't go thinking that you've won the war against the flu. Before I go to that big petri dish in the sky, I will find a suitable replacement. Be warned.
Mr. D, a diabetic patient, came into the clinic with exercise-induced leg pain, which would go away if he stopped a minute. And lately, it's been coming on with walking less than a block. He said, now the pain is meaner and lasts longer after I stop. This is the diagnosis of claudication, a condition of blocked arterial flow to the legs, and I called the vascular specialist for an urgent appointment. 2 weeks later, the patient returned to the office after having had his blocked arteries dilated with a balloon, followed by the placement of stents to hold them open. Happily, he told me he could walk for miles again. His vascular doctor had started dilating medicines, daily baby aspirin, and lipid meds, and I renewed my encouragement for Mr. D to eat fewer calories, exercise daily, keep his blood sugars controlled, and possibly, most important, try to stay off that darn couch, except for short periods of time. The narrowing process, called atherosclerosis, occurs because of genetic tendencies, diabetes, smoking, high blood pressure, high blood lipids, and even normal aging. Arteries usually narrow gradually, but atherosclerosis can sometimes trigger a clot and a sudden, complete blockage, resulting in an acute, sudden, and devastating event. It can occur in coronary arteries of the heart, cerebral arteries of the brain, renal arteries of the kidneys, and peripheral arteries of the legs. And in general, when it's happening in one, it's happening in all. Narrowing of blood flow can deprive muscles, skin, ligaments, and nerves downstream of precious blood flow, and then there follows an aching and agonizing hurt that would bring anyone to their knees. When it happens in the legs, like what happened with Mr. D, the pain symptom is called claudication, and the condition is called peripheral artery disease, or PAD. PAD affects 5% of all people over 50, but more than 30% of all diabetics in the same age group. There can be a curveball with diabetes or with aging, as these people sometimes lose feeling in their legs and feet due to nerve destruction, setting them up for PAD without pain. The presenting symptom then would be painless sores on the feet which won't heal. This is especially treacherous because without good blood flow, the healing is very slow, and the patient without pain is not as motivated to do the work required to heal ulcers. Leg pain that goes away with rest may not sound so bad, but peripheral artery disease is one of the most formidable challenges in modern medicine. And I would say that we're going to get those questions, unanswered questions, up on our site by Monday. We won't have them out there until Monday, so don't give up on us. Well, it's a great big thank you to our guest, Dr. Michael Bacharach. We sincerely thank you for being, traveling here on your own dime and being our guest. A wonderful show, wonderful interest in the audience.
Thanks very much, Rick. Appreciate it. It's nice to be here.
Good. The state is in a widespread flu season. Almost 4% of K to 12 students are absent due to illness. Don't delay. Get your flu vaccine now to reduce your chances of catching the flu bug this season. See the chart. Look at it. Skyrocket. So it's time to get your flu shot. Well, that does it for tonight. From all of us here at On Call with the Prairie Doc, until next time, stay healthy out there, people.
Dope, weed, Mary Jane, or miracle drug? What should we call it? Is there a case for medical marijuana? Next time, On Call with the Prairie Doc.
Major funding for On Call with the Prairie Doc has been provided by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On-Call Television as it continues to open doors for important medical information.
And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota.
And with the ongoing support of these individuals and institutions.
Brookings Health System,
Ophthalmology Limited,
South Dakota State Medical Association,
Avera Heart Hospital,
Dakota Allergy and Asthma,
Fishback Financial Corporation,
Vance Thompson Vision,
Aberdeen Asthma and Allergy,
Black Hills Medical Society,
Dakota Bank,
Orthopedic Institute,
Physicians Care Sanford Clinic Community Service Committee,
Regional Health,
and Swiftel Communications.